today's topic is, I think, foremost on everyone's minds and one of the most urgent priorities in medicine today. So you know that probably there are 6 million people or so in the United States and maybe around 60 million people around the world living with Alzheimer's disease. Since the disease begins decades before the onset of symptoms, there are untold numbers actually who are living with pre-symptomatic disease and don't know it yet. As age is one of the biggest risk factors, of course, for Alzheimer's disease and other dementias, given the fact that there are 1 billion people over the age of 60, that number will double over the next few decades, and the proportion of the population over the age of 80 will triple, I think this has become an existential crisis, actually. And there are a few health conditions that are of greater concern to people in general, and therefore it's a very high priority in medical research. It's especially important, I think, a topic for Atria, since we know that many major diseases are predictable, preventable, or identifiable at its earliest and pre-symptomatic phase, including Alzheimer's disease. However, there are important sensitivities around early disease detection when no treatments or cures are yet available. So we look forward to digging into that today, and we have truly one of the world's foremost experts in Alzheimer's disease and dementia to dive into this topic today. Dr. Ron Petersen, who I'm fortunate to call a longtime friend and colleague, is a professor of neurology at the Mayo Clinic. He is the Cora Canal Professor of Alzheimer's Disease Research and a Mayo Clinic Distinguished Investigator. He is the director of the Mayo Clinic Alzheimer's Disease Research Center and the Mayo Clinic Study of Aging. So Ron, we are truly honored to have you as a fellow of the Atria Academy of Science and Medicine. And we thank you very much for your willingness to share your time and your expertise with us, especially on a beautiful sunny day in Rochester, Minnesota.
Well, thanks so much, Dave. It's truly an honor for me to participate in this symposium series and participate with other colleagues on the Atria Academy of Science and Medicine. I've listened to several of the previous presentations and trust I probably will not live up to those expectations, but it is a prestigious group and I'm honored to participate. Thanks so much for the kind words also about our work at Mayo that you contributed to over many, many years. And Alzheimer's disease has been my area of interest for literally decades, and I hope to present some of, at least from an N of one, meaning my perception of where we are right now with regard to the disease, and some controversial topics at the end. So I hope to engage the audience in a Q&A later on to address some of these ongoing issues. So here are my disclosures. Usually you go by this tachistoscopically, right? You know, flash it up, say, here it is, and go on to the next one. But I'm going to stop here because on the left, I've outlined several of the companies with whom I've had some interactions. But due to the right-hand column, what is it, the fourth one down there, the U24, which is a grant from the National Institute on Aging for the Alzheimer's Clinical Trials Consortium. I'm a co-principal investigator of that, and therefore that precludes me from having any meaningful, significant relations with any companies because we interact with companies along the way. So while I do interact with companies on the left with regard to diagnostic criteria adjudication, it's to a minimal amount because of the restrictions from the NIH. So after all is said and done, I still drive a Yugo. So here's where I'd like to go today to really outline where we've been in the past, where we are now, and most importantly, where we're going to be going in the future. So Alzheimer's disease diagnosis. Certainly when I began, and Dave, probably when you began too in the field, when we saw people with a memory impairment, we tried to classify them as either being normal or having dementia. Now, we got better over the years at making the dementia diagnosis a bit earlier, but it still was dementia. Now, let me stop right here. I know this is a very sophisticated group, but we in the field have confused many. What's the difference between dementia and Alzheimer's disease? So dementia is a syndrome, a clinical syndrome, meaning I'm not remembering as well as I used to, I'm not thinking as well as I used to, It's affecting my daily function. That's dementia. Then you say, okay, what's causing it? Well, up and away, the leading cause of dementia in older people is Alzheimer's disease, the neurodegenerative disease of the brain we'll talk about in a few minutes. But Alzheimer's disease is one form of dementia being the overarching syndrome. But again, back 20, 30, 40 years ago, you were either normal or you had dementia. Gradually over the years, Dave mentioned that this construct of mild cognitive impairment has come into the fore, meaning that there's probably it is a continuum, no doubt about it, but there's probably a stage where people are partially symptomatic, maybe forgetful, more forgetful than they used to be, and maybe more forgetful than they ought to be. And this has been characterized as mild cognitive impairment. Yet functionally, they're fine. They're driving their car, they're paying their bills, they're doing their taxes. To the casual observer, they look normal. But they know, we know, people around them, that their memory's not quite what it used to be. So this continuum sort of gets divided up, although it's really arbitrary. The difference between preclinical MCI dementia, arbitrary. Yet I think most clinicians and research community members have come to realize that this is kind of a useful construct to investigate the disease, Alzheimer's disease, earlier than the dementia stage. Well, 1984, how many years ago is that? This is the paper by Guy McCann and colleagues who really characterized what Alzheimer's disease was and really held court for decades. They defined Alzheimer's disease as a clinical pathologic entity. And by that they meant that the people would have this syndrome of forgetfulness affecting their daily function, probably dementia, and then we as doctors would do these rule out exercises, make sure it wasn't a brain tumor, hydrocephalus, or a stroke. Didn't find anything, and we'd say, must be probable Alzheimer's disease. We couldn't say definitive Alzheimer's disease until the person passed away, had an autopsy, and we looked in the brain for plaques and tangles, the defining features. So that made Alzheimer's disease a clinical pathologic entity over the years. But what we've come to appreciate is that the underlying pathology of the disease, namely the presence of, say, amyloid in the brain, tangles in the brain, really begins perhaps 10 to 15 years before people become symptomatic. So here we have indices of plaques in the brain now that we can see with biomarkers 15 years before people become clinically symptomatic. And that led to the approach, and I must give credit here to my colleague, Dr. Cliff Jack, who's been a pioneer and an absolute leader in the field with regard to thinking. Interestingly, a neuroradiologist, but he's led the way. So here we're plotting biomarkers, indices of the disease on the y-axis, and clinical progression on the x-axis. And back in 2010, published this landmark paper. It's been cited a zillion times about how the disease is probably characterized by the presence of amyloid, A beta there, early during most of the rise is in the cognitively normal stage of the disease process. After that occurs, then the other feature, the defining biologic feature, tau, is causing neuronal damage, occurs subsequent to the amyloid deposition. Then we see stages of brain structure change, atrophy, shrinkage on MRI scan, and only after all of that's happening do we start now to see the clinical manifestation, the memory impairment in the MCI stage, and the clinical function impairment in the dementia stage. But as you can see, this is a process that plays out over many, many years. And the good news is that if we can intervene back here, we might prevent these clinical symptoms from ultimately developing. At least that's the theory that's prevailing in the field. So 1984, the clinical pathologic definition held forth. In 2011, the National Institute on Aging Alzheimer's Association put together some work groups to say, gee, haven't we learned something about this disease over the decades? Can't we use these biomarkers now to help us refine what we mean? and they convened groups that defined the preclinical stage, MCI stage, and dementia stage based on clinical features as well as the biomarkers present at that time, measures of amyloid and measures of neurodegeneration. In 2018, then, the same groups convened other experts, some of the same experts, to put together what is now the proposed new definition for Alzheimer's disease, namely that Alzheimer's disease be defined as a biologic entity by the presence of amyloid and tau, irrespective of the clinical features of the disease. Now, this is a big deal, and we'll get to this in just a minute. But this is a proposal that's out there. The thinking here is let's put Alzheimer's disease on the same playing field as cancer. So if you have a prostate biopsy and it's positive, you have prostate cancer. If you have a breast biopsy, it's positive, you have breast cancer, irrespective of where you are clinically. And the thinking is let's call Alzheimer's disease then a biologic entity, and that will enable us to intervene hopefully earlier with treatments. And that's, of course, where we're ultimately headed. So this is the paper, again, published in 2018. The paper then, and the thinking, is based on the so-called ATN framework, amyloid, tau, neurodegeneration. And again, lead author, Cliff Jack. So A then is defined by the presence of amyloid plaques. How do you pick those up now? Well, you can do it with biomarkers of CSF, lumbar puncture, low A beta 42 or a 42 to 40 ratio is low. Amyloid PET scans, if they're positive, we'll give you that index. And maybe, and we'll get to this in a minute, maybe blood markers, plasma markers, will also give us an index. On the tau side, then, we have the same kind of features. We have elevated phosphorylated tau in the cerebrospinal fluid. We have positive tau PET scans and maybe plasma markers for p-tau 181, 217, and other isoforms. So these are the two defining features of Alzheimer's disease by biomarkers now in the proposal. Then the N feature is an index of how far the disease has progressed. So neuronal injury, neurodegeneration, you can see this on MRI with shrinkage, atrophy. You can see it on various metabolic patterns of FDG PET. In the CSF, total tau may be an index of neurodegeneration. Again, in the blood, maybe neurofilament light will give us an index of this. Well, this was published in 2016, and as you can imagine, it's been investigated, and suggestions have been made that perhaps it should be expanded. What about vascular contributions? What about little strokes in the brain? What about inflammation? What about other players in commonly seen in aging, alpha-synuclein, Lewy bodies, TDP-43? So maybe the ATN framework should be expanded, ATN-V, maybe ATN-VX. In any event, I think this was a stimulus for really putting the disease on a biologic basis. So again, the 2018 proposed research framework defines the disease on the basis of the biology, stages the disease on the basis of these neurodegenerative markers, but this is still a research construct. So AD now was being proposed as a pathologic change in the brain, either at autopsy or with biomarkers. Symptoms, how forgetful you are or not forgetful, is not part of the definition. And so for all of us, I'm a clinician, as all of us as clinicians, this is a major shift in thinking. So I've talked about biomarkers. What are they? We kind of know, cholesterol is a biomarker of vascular disease and heart disease. So a biomarker is a measure of brain pathology that can be obtained in living people, and they're proxies for pathologic changes occurring in the brain. So for Alzheimer's disease, we're talking about imaging, or we're talking about biofluids, cerebrospinal fluid, maybe blood, maybe plasma down the road. So let's take a look at some of these biomarkers. Neuroimaging in Alzheimer's disease, amyloid imaging, huge breakthrough, probably 10, 14 years ago now by folks at the University of Pittsburgh in particular. Chet Mathis and Bill Klunk characterized PIB is Pittsburgh Compound B, which is the tracer that they discovered that will actually detect the amyloid protein in the brain. So here we're looking at a cross-sectional PET scan of the brain. The head's up here, the back of the head's here, cognitively normal, mild cognitive impairment, dementia due to Alzheimer's disease. The yellow-green stuff here is non-specific binding. It means that the scan is negative. To the extent you see redness here in the mild cognitive impairment, redness in the dementia stage, we in fact are seeing now the presence of amyloid in the brain. So this is an index now that we have a biologic marker for Alzheimer's. But note, these are idealized. So when we go out into the general community and we do these scans more widely, we see that the combination of positive, negative scans can be seen in everybody. So here you have a cognitively normal person in the upper left, negative scan. Bottom left, cognitively normal person, positive amyloid scan. In the middle, we have the amyloid negativity in amnestic MCI. The bottom middle, we have positive amyloid scan in somebody with MCI, and over here, dementia. So the million-dollar question then is, what about these people in the lower left and bottom middle? Are they going to progress clinically? Is this cognitively normal person with a positive amyloid scan going to progress to symptomatic MCI, dementia? Probably, but when? Today, tomorrow, 5 years, 10 years, ever in this person's lifetime? We don't know. So here is a depiction then of the amyloid deposition in the brain on PET scans. The redness is positive here in comparing a person with dementia to an individual who is cognitively normal. And you can see that it's fairly diffuse. Frontal, parietal, temporal, and the sensory motor strips on the top there, the white areas are spared, as we see in the disease, but amyloid is fairly diffusely distributed. Let's look at the other defining feature of Alzheimer's disease, tau imaging now, the neurofibrillary tangles. And here we have a coronal cut. We're looking at the brain straight on, and we have a negative scan here in this clinically normal person who's 84, non-specific yellow binding here in the basal ganglia, not important. But over here, we have somebody with Alzheimer's disease dementia. The redness in the lateral temporal lobe, inferior temporal lobe, signifies this person has the tau PET positivity in the brain. So what does this distribution look like? Now we're looking at the blueness here indicates higher levels of the tau protein being deposited in the brain. And we see that it's a little more circumscribed in the parietal and temporal regions of the brain than amyloid was. Okay, so that's amyloid, that's tau. Those are the biomarkers now that can tell us whether somebody has these proteins in the brain. What about staging now? What about the end, the neurodegeneration? Here we now look at MRI scan and we can look at atrophy patterns. So here's a cross-sectional view of the coronal cut of an MRI scan, normal person, MCI, dementia. And the gray stuff here is the brain, and the blackness is areas of atrophy where cerebrospinal fluid is filled in. The control person here is pretty normal with regard to this is the hippocampus, memory structure in the brain, pretty normal. MCI now, we see a little bit of shrinkage of this hippocampal structure in the brain, and over here in the dementia stage, we see significant atrophy, shrinkage in the overall brain, but particularly in the memory structures. We could put numbers on these. We could be pretty precise as to the degree of shrinkage in the hippocampus areas of the brain. But it's not absolutely specific for Alzheimer's disease. Other things can cause shrinkage in these parts of the brain. So that's why it's an index of disease progression, but not a defining feature. More recently, we've looked at measures of cortical thickness, so gray matter thickness, because as the disease develops, the cortex actually thins, the gray matter structure becomes smaller, and we see here on 3 different projections, the red areas indicate areas of preferential thinning in the brain. And here now is a depiction of the atrophy patterns, the red yellow indicating more atrophy, more shrinkage on MRI in somebody with Alzheimer's disease dementia compared to a normal person. And then finally, we can look at FDG PET. These are glucose PET scans, which are designed to detect what part of the brain is doing what. Glucose is the fuel for the brain. So to the extent that part of the brain is working pretty well, it uses glucose. But to the extent that part of the brain is not working well, we see areas of hypometabolism. So here in the bottom pictures, we have sort of a statistical comparison of what part of the brain is doing what. Let's look at these top two here that are the lateral projections of the brain. On these scans on the bottom here, if you see red, green, orange, yellow, those areas of the brain are not working as well as they ought to or they formerly did. So here on this projection of the left side of the brain, we see the parietal region, temporal region, areas of hypometabolism. That part of the brain's not working well. Over here on the right, we can put numbers on it and do quantitative measures. And if we look at the regions now of hypometabolism, areas of the brain that are not functioning as well, we get this kind of a depiction. So biomarkers have really given us an insight into the brain as to what's going on, what role these proteins are playing, what's the functional implication of these proteins. And I think that the advancement on the clinical side of the house has certainly been significant from an imaging perspective. What about fluid biomarkers? Also very important. Two classes, cerebrospinal fluid and plasma. Here's a depiction of performance on the left, on the y-axis here. We're looking at CSF amyloid levels, where low is abnormal. On the x-axis, we're looking at a PET scan for amyloid, where high is abnormal. So in this bottom right quadrant, we have low spinal fluid amyloid, high PET amyloid, positive, positive. The upper left then is negative, negative. High spinal fluid A beta and a low amyloid on level on the scan, that's negative. The interesting quadrant here, though, is the lower left. So this means that on spinal fluid, the index would be that the measure is positive, and yet the PET scan has not revealed amyloid positivity. And the thinking here is severalfold. One is it may be early, that maybe the fluid reflects the low amyloid before we're seeing a PET scan. It could be you have a person who's so-called low protein producer, or there are some considerations of CSF dynamics, meaning normal pressure hydrocephalus, how CSF flows in and out of the brain that may in fact influence these levels. So in general, pretty good, but there are some caveats. We've done a study at Mayo in Rochester looking at over 800 people with spinal fluid and tried to characterize what the cutoffs may be for this. And again, using a variety of different positivity, negativity measures here on the top, comparing them with a variety of international studies from the Netherlands, from North America, from Australia, from Sweden, and from Alzheimer's clinical trials in this country. All of them seem to line up at about the same range, suggesting to us that our cutoff scores that we derived in the community at Mayo up in Minnesota are pretty reflective of what's going on elsewhere. And this has enabled us, this is not a sales pitch, but Mayo Clinic Laboratories now is offering CSF evaluations for Alzheimer's disease. And interestingly, the one in yellow here, the p-tau to A-beta 42 ratio, seems to be the best index as to whether a person has Alzheimer's disease at this point in time. Positive predictive agreement on the bottom is 92%, negative predictive agreement also 92%. So pretty good for a biofluid measure. What about plasma? You've probably heard a lot in the recent months and years about blood tests for Alzheimer's disease. And I must say they're very promising, and it may in fact be the wave of the future. Here's a study from Sweden, BioFinder study, where these folks have looked at one particular measure called p-tau 217 in the blood, and have found that it is really quite predictive of the positive tau PET scan on the left and an amyloid PET scan on the right, comparing it to measures of cortical thickness, other p-tau measures, hippocampal volume, and a variety of other things. So this particular measure in their hands of p-tau 217 looks very promising. Another study from Washington University, the folks there have been studying individuals with a genetic form of Alzheimer's disease, and Randy Bateman and his team there have found a variety of other p-tau markers, p-tau 217, 181, 205, and a particularly interesting, a ratio of the phosphorylated fraction to the total fraction of these particular isoforms may be indicative. So a lot of work is progressing on this, and blood markers are certainly exciting. What about blood markers in predicting clinical progression? Again, the folks led by Oscar Hansen and the group in Sweden have looked at the prediction of the blood markers. Here we're looking at p-tau 181 and its ability to predict the progression of somebody from mild cognitive impairment to dementia. Their data on the left, Alzheimer's Disease Neuroimaging Initiative data from North America on the right, and they seem to be pretty consistent. So if somebody has clinical MCI, has a positive blood biomarker, their likelihood of progressing more rapidly is increased. So there are a variety of algorithms that have been developed by different people. The folks in St. Louis at C2N company there, using a precivity test, which is an amyloid A-beta 42:40 ratio determined by mass spectrometry, combining it with age and apolipoprotein E genotype, have demonstrated that the probability of predicting positivity of amyloid on PET is quite high. Areas under the curve in the high 0.8s, the low 0.9s. And again, the Biofinder group from Sweden has prepared an app for research and education, not for clinical practice, but combining these features, mini-mental score, age, sex, plasma, p-tau 181, NFL, in predicting what's going to happen to a person, say with subjective cognitive decline or mild cognitive impairment over the next 2, 4, or 6 years. I don't think any of these are going to the bank yet that we should say this is the definitive way to approach it, but it certainly is exciting that we may be getting these combination of clinical features and biologic indices to predict who's going to progress. Well, we've been doing some of this work up in Minnesota at the Mayo Clinic, and in particular, Dave mentioned the Mayo Clinic study of aging. This is a kind of, we think, a unique study up here in Rochester, Minnesota, where we've been doing a population-based study of individuals who live in our community. We've seen probably almost 7,000 people over the years. We keep about 3,000 active, and most of them, when we recruit them, do not have dementia. They may have mild cognitive impairment or be cognitively unimpaired, and we span about 6 decades of aging. The key feature of this study, though, is that we randomly sample people from our community. As most studies, very good studies, usually take volunteers that are word of mouth, advertising, whatever. We, because Mayo Clinic is a big place in a small town, we provide virtually all of the medical care. We and the Olmsted Medical Group across town provide virtually all the medical care for everybody in the community. That enables us then to develop these techniques for actually randomly sampling people who live here. And that enables us then to really study these biomarkers in a general community setting. People who also have high blood pressure, have diabetes, have anxiety, depression, we include all of them because we want to see how these markers perform more generally. So the study of aging actually has its roots going back to 1986, but the population-based framework began in 2004. It's It's been funded by the National Institute on Aging, and we're in our fourth cycle at present. So back in 2004, we started sampling 70 to 89-year-olds because that was sort of where the action was with this disease. And we randomly sample people and we see them back every 15 months or so. But as time evolved and the field evolved, we realized that if we're going to look at other biomarkers like amyloid imaging, and remember that slide earlier that the disease process begins 10 to 15 to 20 years before symptoms, maybe we need to go back earlier. So we dropped down to 50. And then when tau imaging became available, we actually dropped down to 30. So now we're sampling 30 to 90. Everybody gets a complete evaluation. So we're not saying if your mini mental score is less than this, you get this. If your mini mental score is that, you get this. We do everything on everybody because we're trying to characterize the totality of the aging and cognition picture. Left-hand, busy slide, left-hand column, a nurse study coordinator interviews the person, goes through the medical history, medications, family history, and asks permission to get some information from somebody who knows the individual well. So sort of a study partner. Middle column is everybody seen by a physician, mental status exam, review of medical history, and a neurologic exam. Right-hand column then is the cognitive assessment. We do 9 tests in 4 cognitive domains. Each of the individuals then, the clinicians, forms his or her own opinion on what's going on. And then at the bottom, we get together weekly for a consensus conference to discuss what we all thought and enter the information into the database. So here's what the cohort looks like at present, equal number of men and women by design. And you can see that it goes from 30 to 90, 90 plus, but in fact, we focus on 60s, 70s, and 80s. As you can imagine, we've acquired a lot of stuff over the years. So we've seen thousands of people. We have MRI scans on many, many of them. Over the years, serial MRI scans. We have blood on everybody for genetic purposes, DNA. We have plasma serum on them. And we're going to expand the cohort to gain increasing power for some of our studies. And the yellow on the bottom there really indicates the value of this. So we've done over 1,200 lumbar punctures on these individuals, giving us the CSF. We've done thousands of FDG PET scans, thousands of amyloid PET scans, and tau PET scans as well. Again, in the general community. So what do these data look like then? So we've looked at now how these biomarkers perform across the continuum in a general population. And Cliff and the team published this paper looking at the age-specific, sex-specific prevalence of these various markers, A, T, and N, in the general population, age 50 to 95 years. Busy slide here, I won't take you through all of it, but women on the left, men on the right. Here is the curve. I'm sorry, on the bottom here, we should have ages 50 on the left out to about 90. So we see that the A minus, T minus, N minus, meaning no amyloid, no tau, neurodegeneration's absent, is high in 50-year-olds. But by the time you're 90, not so much. Things happen. And the things that happen are these things. And again, I won't bore you with all of them, except to say that this white curve now is A plus, T plus, N plus, Alzheimer's disease. So combinations of these biomarkers happen in the middle, some change, go up and down, and these are informative. There's a little bit of a sex difference in them, but this study has enabled us and the field to appreciate how these biomarkers for defining Alzheimer's disease, in fact, perform in the general population. So based on that, what if you define Alzheimer's disease now based on the presence of these biologic features? Not how their memory is, but how their biologic characteristics are. And so Cliff and we looked at this a few years ago saying, what do the numbers look like? And came up with, again, women on the left, men on the right. Bottom line is if you define the disease biologically, by positivity on those biomarkers, the numbers are much higher than they would be if you wait for the clinical diagnosis. Makes sense. If the disease begins 10 to 15 years before clinical symptoms, and you're now defining the disease on its biologic features, it makes sense that you're going to see more of it. And in fact, that's what happened. The prevalence of A plus T plus exceeded the clinical diagnosis at any age. When you get up in the 80s, it's 3 times what you would see based on a clinical diagnosis. And most of the differences are due to asymptomatic Alzheimer's disease. Is this important? Yes, it's important, because if you're going to design a clinical trial now to get at the underlying biologic features of the disease, these data are important to tell you when you should start, what group, at what age, because now you know the frequency of these pathologic features when they're asymptomatic. So what about the blood markers then? We talked about how they perform for the Swedish group, which is probably leading the world in these kinds of studies. How do they perform in our general community? Led by our colleague Michelle Melke, a couple of months ago actually published this paper in Nature Medicine, looking at how on the top here we have plasma p-tau 181, one of the measures, plasma p-tau 217 on the bottom, and you can see they kind of go up by age. But now, because we have biomarker information on these people, imaging studies in addition to their blood studies, we determined that almost all of that increase in age is due to only those people who are amyloid positive. So the markers stay relatively flat if you don't have amyloid. So these blood markers now are an index of amyloid positivity in the brain. The other factor that came out of this study, the other finding that came out of the study, is because, again, we know these are people who are patients, we know their medical histories. And what we found was that on the bottom here, outlined in blue, is the relative weight of amyloid positivity as the plasma marker, the blood marker, detecting amyloid positivity. What I just showed on the previous slide now appears here. But if we look at their medical histories, these are people with CKD, chronic kidney disease. So they have some degree of renal failure. The blood test is impacted by the degree of renal failure. And it doesn't end there. Stroke, myocardial infarction, obesity. So we know that body mass index affects these measures. So while these blood markers for Alzheimer's disease are exciting, tantalizing, and hopefully indicative of where the field is moving, we may have to take a step back and say, well, wait a minute, we just can't interpret a blood marker by itself. We need to know more about the person's medical history. And this is just a slide, busy slide, don't worry about it, but it did show that, again, these markers in the blood do correlate with amyloid positivity on PET scan, less so tau PET positivity, but nevertheless, they do in the general community still reflect what's going on in the brain. So one of the arguments, I'll get to this in just a moment with regard to when we start talking about treatments for Alzheimer's disease, a lot of discussion out there in the field regarding, is amyloid really a player in the disease? Or what about the people who go through their entire life clinically normal? You look at their brain at the time of autopsy, it's full of amyloid. So amyloid didn't cause dementia in this person, so therefore maybe amyloid is kind of an innocent bystander, but is not really central in the disease process. So again, because we have the ability to look at the entire community, and what this study indicated was, what is the likelihood if you're amyloid positive? 2 things can happen. Upper left, you're alive without dementia. You can either go to become alive with dementia and then die, or you can go from alive without dementia and die. Everybody's going to go down one of these pathways. And so we started asking the question, what happens about people who are amyloid positive and do not die? I'm getting into a bit of the subtleties of epidemiology here. I'm not an epidemiologist, so I apologize for that. But basically, in many studies, when people drop out of the study, they often drop out. Why? Because they're sick or because they're developing cognitive impairment, and then we lose them. We don't know what happens to them. Well, in our study in Rochester, Minnesota, because they're our patients, even when they drop out of the study, we can follow them through the medical record. They've all given us permission. 97% of them have given us permission to use their medical record for research. So when somebody drops out of our study, we know what happens to them. Do they develop dementia? When do they die? What do they die of? And that enables us to do this type of a study. And so in the bottom left here, we have death before dementia, basically death rates. In the upper right, we have dementia developing over time. And in the bottom right, we have those individuals who died after they developed dementia. And what this enabled us to do then was to put together the formulation of what happens with amyloid positivity. So it's a busy slide. Let me explain it to you. The top part here that I've outlined is M means men, male. The plus minus after the M refers to their apolipoprotein E4 status, a risk factor for developing dementia genetically. The high, moderate, normal means what their amyloid scanned level was. How much amyloid did they have in the brain? On the right, then, we have 3 age strata, 65, 75, 85. So what you can see from this part is that and what we're plotting here is lifetime risk of developing dementia. And you can see that if you're a man and you're apolipoprotein E4 positive and you have high amyloid level, your risk of developing dementia over your life is 50 to 75%. Pretty high. Now you look at women, same kind of picture, but they're even shifted further to the right. So if you have a high level of amyloid in your brain and you're a man or you're a woman, your likelihood of developing dementia in your lifetime, accounting for death now, because we know we can take death out of here, so you didn't die, but you're still alive, the likelihood is 50 to 75%. So we're concluding that amyloid is not an innocent bystander, but in fact is a causally related element in developing dementia over your lifetime. And again, this can only be done in a population-based setting where you have capture of people throughout their entire lifespan. So that sets the stage then for what about the treatments? The treatment horizon is fuzzy, I'll say, but I don't think it's bleak. I don't think it's as bleak as you might read in New York Times, other newspapers, other media outlets that characterize what's going on in the field of treatments for amyloid and for Alzheimer's disease. So where are we in 2022? Basically, there are two types of treatments for Alzheimer's, symptomatic or disease modifying. We've had symptomatic treatments for decades. We've had these drugs, cholinesterase inhibitors, donepezil, rivastigmine, galantamine. These increase the amount of acetylcholine in the brain, an important neurotransmitter involved in memory, behavior, activation, a variety of things. Important, it goes down in Alzheimer's disease, but it's not, it's an effect of the Alzheimer's process. We can modulate it a bit, it helps a bit, but it doesn't do anything for the underlying disease process. The bottom there is an NMD antagonist, memantine, another neurotransmitter in the brain that you modulate. It helps people a bit. We use them all the time because we think it might help with the symptoms, but it's not getting at the underlying disease. For that, we need what are called disease-modifying therapies. And here we now get into this scheme again, saying, look, if this is the process, shouldn't we be intervening back here to modify this disease process before the symptoms develop? So the disease-modifying therapies under investigation now are going after the blue curve, the A-beta curve, or the gold curve, the tau curve, those two defining features of the disease. And this is a slide. Several of the slides I'm presenting now are from the various companies, and they've all given me permission to use these slides. I'm not leaning toward one company or another, but they have the best depiction of what's going on. So here's a slide that depicts the amyloid pathway from its misprocessing with the amyloid precursor protein is then cut by a couple of enzymes, beta secretase and gamma secretase, that produce these monomers, which are single little abnormal protein fragments. They can get together and clump into oligomers of various sizes, which then go on to become protofibrils, fibrils, which end then with the amyloid plaque. So the images I showed you earlier of the Pittsburgh compound B scans were depicting this stage of the disease, the plaque stage of the disease. The drugs you're hearing about out there now that are lowering amyloid levels in the brain are lowering the plaque stage of the disease. We'd like to intervene here. We don't have good measures of this, and I'm not sure that all of the drugs are all that good, but we don't really know how to measure those oligomeric forms of the disease, yet we infer that they're certainly there and are maybe very toxic in the disease process. So one other issue I'd like to bring up, and we can talk about this in the Q&A, is what are reasonable clinical expectations of interventions with Alzheimer's disease therapies? I'll expand upon that in just a minute. We use a bunch of clinical instruments to measure, are these drugs working? But I must admit, they're pretty blunt. They're not the sharpest, getting at maybe the most definitive features of the disease. Nevertheless, these are what we use. So amyloid's a major target. One of the drugs out there, the one that's created the kerfuffle over the past year or so, is Aducanumab. 2 studies, one was positive, one was negative. Here are the data from the positive study with regard to its ability to lower amyloid. Placebo up here, low dose, high dose. So it certainly looks like it reduced the amyloid protein levels in the brain. Then, did it have significant clinical impact? The features over here, all of these markers for the high dose were statistically significant. But the question out there is sort of, so what? Statistically significant when you're dealing with 1,600 people in a study, is it clinically meaningful? Maybe yes, maybe no. We'll come back to that. Nevertheless, statistically significant in the one positive study. But the other study, parallel study, subtleties in the way it was executed, but designed similarly, also lowered the amyloid levels in the brain, low dose, high dose. But the clinical impact was virtually nil. Okay, when you looked at the high dose here, the changes in these various clinical instruments on the left, not very impressive. So you have a positive study, you have a negative study. I'll come back to that. Another drug out there, this is by Eli Lilly, Dananamab, had reported its results a year or so ago in the Trailblazer study, and these were pretty exciting findings. Again, they showed that actually Dananamab resulted in amyloid reduction over time, and it was proportional to the amount of amyloid the person started with in the brain. They used different clinical measures, maybe a little more sensitive, but again, a composite instrument. And they found that when you remove amyloid plaque from the brain, it was associated with less clinical decline. But look at the slopes of these curves. Not very dramatic, but something going on. Nevertheless, it was a subtle but a significant finding. When they then got together with their statisticians and some other individuals to model the reduction of amyloid in the brain and clinical impact, they came to the conclusion that reducing amyloid plaque does in fact slow the disease progression. So Clinical Path Institute here generated these data that suggested that in fact it may be useful. Lecanemab, drug by Eisai, also now lowering plaque level in the brain in a dose-dependent fashion. So this compound also lowers the amyloid plaque level in the brain. They used some different clinical instruments, something called the ADCOMS, which is a combination of these various clinical measures that are out there. And they showed that, in fact, it slowed clinical progression on the ADCOMS measure and its component measures as well. Significant? Yes, maybe. Clinically meaningful? Perhaps. But I think that the direction in which these drugs are moving is very, very similar. The last one then is Gantenerumab by Roche. Relatively little data on this yet. They're going to be giving a readout, I think, in the third quarter of this year on their Graduate 1 and Graduate 2 studies. They had studies that they did years ago, so-called Scarlet Road and Marguerite Road studies, and they followed people. OLE means open label extension. Those studies were negative, were stopped early, but what the Roche folks did was said, maybe we're underdosing. So they increased the dose of Gantenerumab dramatically, and now are reading out suggestions in their open label extension data that, in fact, this is having an impact. So here's a composite. On the upper left, we have Lecanemab. Lower left, we have Dananamab. On the right, we have Aducanumab. So all of these antibodies appear to be lowering the level of amyloid plaque in the brain. And if you believe that amyloid is one of the defining features of the disease, that's probably important. But the clinical manifestation of this has yet to be demonstrated. So let me go back to my original question. Are we asking too much of a single intervention? If we intervene on amyloid only, or only tau, should we expect a huge clinical impact? The benefit might, in fact, be quite modest. And I think we need to think about amyloid as being part of the process, but certainly not the end-all, be-all. So if you go back to my earlier slides where I offered the contention that amyloid builds up over decades, and then we take a drug now that reduces that amyloid plaque level by 10, 15, 20, 50% over the course of 12 months or 18 months, is it likely that we're going to see the significant clinical impact of that amyloid reduction at the plaque stage of a process that's been evolving over decades? I think we can, but I don't think it's going to be like penicillin. We're not going to see people turning around. And what we're really talking about here is a change in the slope of progression. So we're not talking about clinical improvement. We're not talking about turning people around. We're just trying to slow the disease down. And if that's our goal, what kind of metrics need we consider? I was at a meeting a couple of weeks ago in Washington on this very issue of the drug trials that are out there. The companies were there. The FDA was there. Center for Medicare and Medicaid Services were there. Academicians were there discussing this issue. And there was one individual, the bottom right there, Dr. Yaning Wang, who was with the FDA for 18 years, just resigned recently for other reasons, not because of any particular action, but resigned. But he was head of the clinical pharmacology group at the FDA. And he put together this slide. And I think this slide is informative for the field. So on the y-axis here, down means we're seeing clinical improvement. On the x-axis to the left, we're seeing removal of amyloid plaque from the brain. So the best possible world is down here, clinical improvement and reduction of amyloid. So he plotted these studies that have been done over the past number of years. So this is an early study of a drug called Bapineuzumab, the early studies of the Gantenerumab, the Roche drug that I mentioned, the Crenuzumab there in the purple, and those of you who've been attentive to the news in the last 24 hours, there's another negative trial of Crenuzumab in the Colombian cohort, autosomal dominantly inherited. But note that all of the others are what are called secretase inhibitors, so meant to block the deposition of amyloid in the brain. But all of these kind of hover around 0 and 0, right? There's no change in the amyloid protein plaque level in the brain, and there's no real clinical improvement. So these are kind of blah. They're not showing us much of anything. But the newer antibodies now that I've outlined may tell a bit of a different story. So here, Lecanemab is in the gold triangles, and Dananamab is in the green home plate there. There certainly is a suggestion here of improvement clinically and reduction of amyloid protein. And if you throw in the Aducanumab studies, 3 of them, they kind of line up as well. Now, there is an outlier out here, and this is the high dose group from the failed study, the ENGAGE study by Biogen and Aducanumab. No question, didn't line up. But everything else in this same mechanism of action, the slides I showed you earlier about the amyloid reduction, certainly suggest that something's happening. If you take away those studies that didn't move amyloid plaques at all, you kind of get a feeling that there is, in fact, an effect. Removing amyloid correlates with a lower, a slowing of the rate of progression. It's not huge, it's not dramatic, but it may be real. Dr. Wong then went on to, being a clinical pharmacologist, went on to say that, if you looked at exposure data, that is cumulative amount of drug on board, and correlating that with the amount of clinical change, you do get a suggestion that people who are exposed to more of the drug in the Aducanumab trials, in fact, reflected in clinical improvement. Won't go into detail on this, and we can talk about this later if you're interested, but this discussion gets into what the study projected to find, which was approved by the field, approved by the FDA, how much lowering they expected. And what actually happened in the study was not too far off in the positive trial, not the negative trial, but in the positive trial for this. So Dr. Wong concluded that there was, in fact, a consistent relationship between amyloid lowering and clinical slowing across many compounds, providing a quantitative basis for the compound dose selection. Convincing evidence to support Aducanumab's approval, and many misconceptions due to lack of understanding about details. And he states that the FDA statisticians made some mistakes in the way they analyzed the data. And he himself, he's a clinical pharmacologist, but he's a statistician. So I think he knows what he's talking about. So I've done a couple of things about, where are we now? What do we do about the patient? Where's the patient in this whole mix, and the awkwardness of the field with regard to patient interactions? So where are we? I think the interventions on amyloid and tau are consistent, but they're modest. Not that we shouldn't do this, not that we shouldn't go there, but I think that we have to modify our expectations. Let me wrap up now by just saying then, are these plasma markers, these blood markers, the hottest thing? Are they ready for clinical use? I think we can think about that. So if you look at the top line here, the blue progression, you have somebody with a cognitive complaint, you do a history, you diagnose mild cognitive impairment or mild dementia, you do an MRI scan, they seem to be safe for intervention, you check to make sure they have amyloid in the brain, you intervene then you do ApoE testing for side effects, and then you intervene. The blood tests in this pathway may give us some insight into who is amyloid positive back here, and maybe is the drug working. So, if we go back here, we may be able to measure plasma blood markers of amyloid before you treat, measure the blood markers after you treat, and rather than doing the expensive scans or a lumbar puncture, the blood measures may give us an insight. So I think this is pretty exciting as to where the field is moving in the sooner rather than later. But again, at the end of the day, here's the clinical spectrum: cognitively normal, mild cognitive impairment, and dementia. People become cognitively impaired as they age. Why is that? Well, they may have the amyloid protein in the brain. They may have the tau protein in the brain. But guess what? They may also have something else called alpha-synuclein, which forms Lewy bodies, what we see in Parkinson's disease. These can coexist. There's another protein called TDP-43 that can produce memory impairment in and of itself that looks like the mild cognitive impairment due to incipient Alzheimer's disease. You've got vascular features. Most people as they age will have some, at least microvascular disease. And I mentioned earlier this notion of CSF dynamics, meaning that the flow of CSF can influence our cognitive function. And I'm sure there are other features that that will come into play. So with this complex picture of a typical person in aging, this is what we call Alzheimer's disease. Very important. And in an individual, it may be the important factor. But I suggest that in most people, it's just part of the picture. So again, if you intervene with just an effective therapy here for amyloid, how much of the impact is going to be appreciated in this clinical spectrum, given the other features that may be interacting? Nevertheless, this is where we are. We've got this complexity going on, and the field is very actively now developing biomarkers for each and every one of these components. And why are we doing that? Because ultimately, we'd like to intervene. So I'm thinking down the road, it's not going to be a single treatment, a single drug, a single intervention for Alzheimer's disease, but it's going to be some of this and some of that. And we may, in fact, be developing combination therapy for these kinds of clinical disorders, some of which is due to Alzheimer's disease, but we have to take into account these other elements as well. So 5 years from now, 8 years from now, you go into see your physician, and your physician obtains a lipid screen. So how's your triglycerides, your HDL, your LDL, what's going on, and here's what we need to do about it. What if we can develop a cognitive screen, a blood test that's going to tell you how much A beta you might have, how much alpha-synuclein you might have, and then hopefully, and here's what we do about it. And we do this already. Hypertension. How do you treat high blood pressure? One number. How do you treat it? Could be a diuretic, beta blocker, calcium channel antagonist, angiotensin receptor antagonist, et cetera, et cetera. Different mechanisms to treat the same symptoms. How do we treat HIV/AIDS? Combination therapy. Many cancers, combination therapy. I think this problem is sufficiently complex that it's not going to be a single silver bullet, but really a combination of entities. So I'd like to thank my colleagues at Mayo at the 3 sites who really have contributed to the data that I presented from Mayo, and I'll take the responsibility for misrepresenting the authenticity of it. But Dave, I want to again thank Atria Academy of Science and Medicine for allowing me to share some of these thoughts with you, and I certainly would be happy to entertain any questions.
Well, Ron, thanks again. Listen, have a great weekend. Enjoy the US Open. Happy Father's Day, and happy Father's Day to all you fathers out there. Have a great weekend, everybody. Thanks again, Ron.